Greetings, I'm Hong Shichu. I'm thrilled to meet you all in this webinar session. In this session, I want to talk about what the vet pathologist is and how we diagnose a tumor and how pathology could help evaluate the prognosis. Different vets play different roles in the whole process of diagnosing diseases, and the pathologist also plays an important role in this process. And then also talk a little bit about just different types of tumors commonly seen in the small animal practice and how we basically go about diagnosing different types of tumors. Okay, what is pathology? Pathology refers to the study of and the diagnosis of disease. So we don't just diagnose tumor, but a lot of pathologists are also involved in the research aspect of understanding how disease occurs in the first place. Here you can see the microscope, epithelial cells, and inflammatory cells here, and a bunch of pathogens. These are the things we are dealing with. Many people may think of a human medical examiner potentially like a forensic thing or something like that. Pathologists are a big component in human medicine world as well as veterinary medicine. By and large, pathologists serve as diagnosticians but serve other roles as well. Some pathologists are engaged in drug research in some pharmaceutical companies, while some work more in diagnostics teaching and veterinary schools. If a company trying to develop a new drug for a specific disease, when they start testing it on animals, pathologists will come in to determine whether the drug is safe or not. What organs does it affecting? When we make dosage higher, will it be potentially safe for human trials? Therefore, it's a very important role for vet pathologists. There are also pathologists working in government departments like the CDC. I put this picture up here so you can see this obvious mass on the dog's face, and this is really probably the primary way that the vet pathologist function is diagnosing what this is on this dog. The clinicians may remove the lump or biopsy the lump and then submit the mass to the lab. Most of the time, we observe it under a microscope and discuss with the clinician or the surgeon instead of facing the patient directly. Pathology can be split into anatomic and clinical pathology. I'm an anatomical pathologist. The samples handled by clinical pathologists are slightly different. Most of their observations are cytology, which is a single-cell samples extracted from a lump and usually collected with a small needle, as shown in this picture. You don't see the full tissue structure, but can often get a lot of information about a case from just looking at basically a cell smear that comes out of a mass. In addition, they also participate in blood work analysis, especially challenging blood work cases, and analysis of fluid samples like the urine, ascites, or pleural fluid. They will be able to see if there are any bacteria here and what kind of cells in the sample, which is the focus of clinical pathologists. Anatomical pathology is a bit different. The primary things we do diagnostically are biopsy and necropsy. Biopsy refers to a piece of tissue taken from a living animal, so tumor biopsy is very common. But we have also done lots of biopsy for other reasons, such as autoimmune skin disease, inflammatory skin disease, and inflammatory bowel disease. Anatomical pathology is a bit different. The primary things we do are biopsy and necropsy. Biopsy refers to a piece of tissue taken from a living animal. So tumor biopsy is very common, but we have also done lots of biopsy from other reasons, such as autoimmune skin disease, inflammatory skin disease, or inflammatory bowel disease. And there are many different things, not just tumor. So this shows you an example of a lymphoma in the lymph node, which is a common pathology finding we observed. And then we also do necropsies. Necropsy refers to the examination of the whole animal carcass. So we often try to determine the cause of death by doing a necropsy. For example, if an owner comes home and finds their dog died on the kitchen floor, the owner and the clinician may want to know what happened. I had a case before. It was a Dutch Hound with IVDD, and the patient died the next day after surgery. And the surgeon wanted to know what's going on in this patient. And after necropsy, we found that this patient had subdural hemorrhages, like this picture, and degeneration and necrosis of neurons, which was the cause of death of this animal. Now we'll talk a little bit about diagnosing tumor, including some information about tissue processing, from the initial problem to how we can get a diagnosis. So you can see this picture again. So really the whole process starts with an owner recognizing that in general something is wrong, and the clinical signs are gonna vary based on what type of tumor we are talking about and where it's located in the body. So the most common examples will be a visible or a palpable mass. So if you got the mass that you can feel either in the dog's skin or even see it on the surface, and the owner notices this and of course brings it into the vet and see what the problem is. But you could have all sorts of other clinical presentations caused by a tumor, such as a pulmonary tumor that could cause coughing or trouble breathing. If an animal has a gastrointestinal tumor, it might gradually lose its appetite, diarrhea, or blood in the feces. If it has a brain tumor, it might have seizures or show signs of behavior changes or collapse spontaneously. If it has a bone tumor, they may fracture their limb before the owner even realizes there's something wrong with it. The physical examination is going to be really important for assessing the visible mass. Because of the book of literature we have accumulated and experience over the years, we can often just based on physical examination and anatomical location come up with a pretty good set of couple different things that could catch that tumor could be. Additionally, blood work can be useful for diagnosing some tumors. There are certain alterations in blood work that are indicated of a few specific tumor types. Radiographs are going to be really important to see things in the chest or in the abdomen. And then in specialized cases, particularly affecting the nervous system, MRI imaging to actually spot the tumor. This is an imaging examination of the chest. There is a huge mass infiltrated the pulmonary parenchyma. Okay, someone brings their dog to the clinic. This dog has been coughing a lot and it's been getting worse recently. The clinician does radiographs and finds this huge tumor in the chest. So here's the heart, and here's where's the lungs located, and you can see that there is a mass in the chest. And this whole opacity is a pulmonary tumor. So immediately, even without involving the pathologist, we know there's almost certainly a tumor within the chest of this dog. There's a cat that had seizures, behavior changes, and has been acting aggressively lately. This is an MRI image of a cat's head, and you can see this irregular lesion and doesn't make sense in the brain. So that might be a brain tumor in this cat. You can get a lot of information just without even involving the pathologist by doing clinical and imaging examinations. When pathologist starts coming in, often the first line of the diagnosis is going to be the clinical pathologist. Typically, if dogs have skin mass or mass in the liver or spleen, you can use ultrasound to hit those with a needle, and they will collect a sample of cells in there, using a syringe to squirt them out on a slide, and then send the specimen to the lab. The slides are scanned well and reviewed by the clinical pathologist. With regard to the clinical pathology, I noticed that you are not interested in lymphoma. You are in the wrong business, because probably somewhere around 30 to 50% of the cases they see the aspirates from lymph nodes that may or may not have lymphoma. This is an example of master cell tumor cytology. All these big cells are homogeneous population with specific blue granules in the cytoplasm. So like clinical pathologists would interpret that as master cell tumor. Where anatomical pathology start coming in terms of diagnosing things in the living animal is once surgery or biopsy sampling of the whole tissue is considered. So for example, this dog may have presented with this mass. They probably would have done aspiration of it. Maybe it come back as highly suspicious for master cell tumor, and they decide we have to take this off. So the dog is gonna come back in for surgery later, and then often they are drawing a line around it like this picture, where they want their surgical margins to be. We'll talk a little bit about what the margin is later. And in this case, they are trying for pretty wide margins, because most of the skin tumor is gonna probably be localized to right there. And to make sure they get it all out, they want to take pretty large margins in certain cases. The two pictures here are two different ways of taking the biopsy samples from the lesion. The left one is true cut biopsy. The right one is skin punch biopsy. The clinician may want to know what this mass could be in the first place, and they take biopsy samples from the mass by these two ways of sampling, and submit the specimen to the lab, and make further treatment or surgical plan according to the pathology report. So the first thing the surgeon's gonna do once they take the mass out or a piece of tissue off and dump it in one of these containers with formalin, which is a mixture of formaldehyde and water. And so what happens is, when it sits in there, the formaldehyde permeates into tissue, causing cross-linking of proteins, so it preserves it and prevents it from decomposing. These containers with specimen inside will be transported to the lab. Then once it gets to the lab, it's gonna go down to trimming lab, where they get these specimens all day. It could be skin masses, little tiny biopsies, or the eyes. Here is an example of ocular enucleation with a mass in the iris. This is how we trim the globe superior to inferior, cranial to caudal, and take the central section with the optic nerve into cassette. Basically, anything that could be biopsied of the dog all comes to the trimming lab. They will be responsible for preparing the tissues for processing and then giving it to the pathologist. So this is an example of how we would go through sampling tissue from a skin mass. There's no hair on the surface because it would have been shaved for surgery. And you can see that this is a bit of diamond shape. Usually when they take samples out of the skin, we get a diamond-shaped piece, ideally with a mass in the middle, and with some tumor-free clean skin margins around the outside, as well as usually a layer of tissue deep to the mass, like a muscle layer, to try to avoid taking the tumor out incompletely, with some tumor left deep in the tissue. So the first thing they usually do is to make a cut all the way across the middle, and then this piece would represent the top and bottom of the mass right here and here. And we make another two cut sections right here and here to get the lateral margins. So with that, we will probably be able to diagnose what it is, because we got a nice chunk right through the middle, and also assess if the tumor extends to the deep edge or to the lateral edge right there, because it's going to be important for what the clinician might want to do next. After we've done this, we still hold on all these tissues for at least a month, because sometimes we don't get the greatest cut out of the first one. Or maybe this whole piece is just all necrosis, because a lot of tumors have a lot of dead tissue in them, and there might only be a little viable tumor. And maybe in the first go round we don't find what we need to diagnose it, so we hold on to that tissue in case we need to go back to do more examinations. Here's the pictogram of perpendicular margin. The tissue is cut perpendicular to the surgeon's plan of cut. Establishing the diagnosis is the most important task. So a section through the mass should be obtained first, followed by sections that help identify the histologic tissue-free margins. When placed on the glass slide, the histologic tumor-free margin and mass can both be visualized, and the distance between the edge of the tumor and the non-neoplastic tissue could be estimated or measured and reported. These two pictograms here are perpendicular margin. Again, the left one is called bread slicing technique of the entire mass. The technique will assess approximately 1 to 5% of the circumferential margin, depending on the size of the tumor and the number of sections taken at the specified intervals. And the right one here is perpendicular margin of points of the compass cut. Two cuts are made at right angles to evaluate the 5 components of the margin, 4 lateral and ventral margin. And the right one here is the modified points of compass cut in the oversized mass to evaluate the margin in 5 directions. In this modification, the specimen is too large to include the margin and the mass in the same section, so the histologic tumor-free margin cannot be observed directly and measured or estimated on the glass slide. So the histologic tumor-free margin of this mass should be reported as N4. The distance of the closest approach of the tumor cells to the histologic edge should be measured or estimated in the field of vision. This can be assessed along the cranial, caudal, both lateral, and the deep margins, and reported as the HTFM. The HTFM varies among histologic sections examined, is influenced by the pattern of tumor growth, the type of excision performed, the trimming protocol, and the total number of sections evaluated. Given the variable nature of the periphery, the asymmetry of some tumors, the minimal amount of the total margin actually examined, and the tissue shrinkage induced by formalin fixation, the HTFM could be reported as a range, like this. M1 is margin infiltrated, M2 is margin is closed, less than 2 mm, M3 is margin is clean, 2 to 5 mm, M4 margin is clean, greater than 5 mm. Here's an example that the HTFM is influenced by different tissue section in the same tumor mass. The HTFM is greater in the upper one, like this, and narrower in the lower one. Then the next step is going to the histolab, where they are going to turn this tissue that's been fixed in formaldehyde into slides. Once the tissue gets there, it goes through all tissue steps that we just kind of general refer to as tissue processing, which is kind of a vague term that covers a lot of different steps. So this machine is an automated tissue processor, and once we put tissue in the cassette, so the tissue goes in the machine in those cassettes, and the machine puts it through a set of steps, get the tissue ready for embedding and trimming slides from it. So the first thing is pumps alcohol into the tissues to get all the water out of cells, then use xylene to dissolve the alcohol, and then pumps paraffin into it, which will allow it to be embedded. After tissue processing, these cassettes are ready to be embedded into blocks. The technicians will fix the tissues in the wax and then chill it on the cooling pad to harden up to make a tissue block. So this tissue gone through all those steps, and then it's in this wax block that can then be trimmed into small tissue sections to put on the slides. The next step is sectioning. The technician is going to take this block over to a microtome, which allows to cut very minute specificity. They're gonna trim sections that are only 5 microns wide, and then those are going to be mounted on a glass slide. So then you have tissue slides ready to be stained. These tissue slides are put into an automated stain machine and stained with hematocillin and eosin stain. The staining steps are shown in this picture, which is the basic stain we use for looking at all tissues initially. Finally, put the multimedium on the slide and cover it with the cover slip. Then we get the stained slides ready to go to the pathologist. This is a picture of HE stained slides, which is a tumor. We can see the nucleus are blue, like this, and the cytoplasm is pink, and we can also see that these are red blood cells. So from that dog coming into the clinic with a skin mass, now is when the anatomical pathologist comes into action. This mass might be an inflammation, hyperplasia, or a tumor. Here we can see that this is a chronic inflammation. This is sebaceous hyperplasia, and this is a benign tumor, trichoblastoma, and this is a malignant tumor, soft tissue sarcoma. I want to talk a little bit about how we diagnose different types of tumor. The main things we use are cell features and patterns of growth. So we know that certain cells from certain organ may have certain appearances. Their nucleus might look a certain way. Their cytoplasm might have certain features, such as little granules of different colors. They might have little vacuoles, little clear spaces. They also grow in specific pattern of arrangement. Cells that form carcinomas often will grow in little islands and nests, like squamous cell carcinoma, which the epithelial cells replicate in a dysplastic way that would not happen in normal biology. We also have sarcomas, which are tumors that come from a different class of cells called mesenchymal cells. Generally speaking, sarcomas are often a little more dangerous on average in terms of risk of causing metastatic disease and the death of the patient. Although carcinomas and sarcomas both can regularly metastasize, different carcinomas and sarcomas are more dangerous than others often. An example is fibrosarcoma, which is common in dogs and cats. The third type is round cell tumor, which includes about 8 different types of tumors. An example of this would be lymphoma, a tumor developed from lymphocytes, that is immune cell, or melanoma, a tumor that comes from melanocytes, normal cells that contain melanin granules and help provide pigmentation to the skin. So the following are something I often observe under the microscope. The first one is carcinoma and adenocarcinoma. The left one is carcinoma and the right one is adenocarcinoma. Epithelial tumors that are malignant are carcinoma and adenocarcinoma. Adeno means that it either comes from glandular structures that you will see in glandular tissue versus non-glandular epithelial tissue. This is an example of squamous cell carcinoma at the left one. Squamous cell carcinoma is a very common skin tumor which is often seen in dogs, but also in cats, especially cats with white face and ears, which are more likely to develop due to the UV damage. Adenocarcinoma is the range in glandular tubular structures, which is different from carcinoma. This is a pictogram of epithelial tumor. The benign types grow as a cohesive sphere of connected cells with even edges. Carcinomas may be infiltrative. The margin is easily observed in perpendicular section, but the HTFM may vary in different parts of an asymmetrical tumor or infiltrative carcinomas. The HTFM in the lower panel is narrower, and this is like the iceberg, like the tip of the iceberg. Sarcoma's overall structure is often quite different. This is an example of a soft tissue sarcoma, especially a tumor called a peripheral nerve sheath tumor, which is commonly seen on dog skin. By observing these two kinds of tumor, you can immediately see that the overall type of tissue structure and the appearance of cells are very different. But even within sarcomas, the variation is quite a bit from different types of sarcoma to the next type of sarcoma. You can see here they are formed these kind of what we call bundles and streams versus little islands and tubules in the carcinoma or adenocarcinoma. And usually these cells are what we call spindle-shaped cells. So they form basically like a flattened out elongated football almost. And when we see this kind of orientation with them forming these streams like that, and with the spindle-shaped cells, those are kind of key things that it is a sarcoma when we initially see that. Then according to the location, the growth pattern, and the features of mesenchymal cells, we can diagnose different types of sarcomas. This is a pictogram of soft tissue sarcoma. Sarcoma grows as an asymmetrical mass with highly irregular edges, consisting of concentric lamination or finger-like extension, similar to a root ball of a tree, like this. The tumor appears completely exist in the upper one panel, like this one, but the tumor cells infiltrate the margin in the lower panel, like this one. This is the list of different types of soft tissue sarcoma, including fibrosarcoma, osteosarcoma, hemangiosarcoma. And there are a couple examples of round cell tumors. Here, melanoma is one of them. This is a skin mass which is infiltrated by these dark cells. They are all neoplastic melanocytes. So if you look at normal skin, you will see a few of these little cells near the junction with the overlying skin surface. But in this case, they have neoplastic transformed and are actually making a tumor in the skin. So that's what the melanoma looks like. And one thing you could see is that you really can't see anything in the cell because it's full of brown pigment, and we can actually bleach the tissue to get rid of that melanin and see what the nucleus looks like, because that's important for determining if we are worried about this tumor being malignant or benign. Additionally, another really common tumor we see is the muscle cell tumor. In the lower power field, you could see all these little cells just kind of organized in a loose, disorganized sheet, and lots of eosinophils around it. The muscle cell tumor cells release factors that will cause vasodilation and predispose the site to bleeding. So often, when we see these biopsies from muscle cell tumors, there's a lot of blood in the tumor and a lot of edema tissue swelling. And then when we look under higher power field, you can see different features in these cells than the melanocytes. When we look at these cells, you can see that they have cytoplasm full of these little blue granules, and that indicates to us that this is definitely a mast cell tumor. So those are kind of the things we are looking at just to give you an idea of the different structures the tumor make and how the cells look different from other cells to get a diagnosis of what types of tumor these are. This is the pictogram of round cell tumor. The tumor grows as a sphere of unconnected cells with an irregular edge. The tumor appears completely exist in the upper panel, like this one, but the tumor cells infiltrate the margin in the lower panel, like this one. This is the list of different round cell tumors, including lymphoma, muscle cell tumor, and plasmacytoma. Many of you probably heard the term margin. You'll hear about this in human medicine as well. What a margin is a section of tissue that the surgeon takes out that's tumor-free. And how big or narrow those margins along with the type of tumor it is will either increase or decrease the concern of, are we sure we got it all? Do we need to consider another surgery or not? We mainly just report them. For example, a muscle cell tumor. If it's really close to the margin, I will be more worried that we didn't get it all because those cells will permeate through the tissue. Whereas if it's a well-defined soft tissue sarcoma with a very well-defined edge, the chance that they got it all is better. So even if the margin are close, they might not be as concerned about that versus another tumor type. So when we see this under the microscope, this is what the margin actually looks like. And this is a really small margin like this here. But it's a benign tumor. So this is a tumor called a trichoblastoma, which arises from the cells that line the hair follicles in the skin. They are almost universally benign, but occasionally malignant. This is a benign one. And then this is the deep margin under that tumor when they took it out in the skin. So this is a very narrow margin that's tumor-free. The margin is probably from about here to here. But because this is a benign tumor and the edge is really well demarcated, it's easy to tell where the tumor stops and where regular tissue ends. The clinician that submit this would probably not be concerned about recurrence. So some of the things when we assess if a tumor is potentially malignant or not is the invasive growth of the tumor. In this picture, this is a case which the surgical margin is positive. As we can see here, the arrow indicated, the tumor cells had invaded into the subcutaneous layer, and the inflammatory cells infiltration was also observed. For many low-grade tumors, the compressed fibrous zone may provide an effective barrier against the tumor growth and infiltration, like the upper one picture. Many higher grade tumors, the lower images here, will expand faster than the fibrous capsule can form, leading to infiltration by neoplastic cells. The reactive zone is an area of nascent and evolving neoplastic activity. Tumor cells can be found beyond the pseudocapsule surrounded by normal tissue, like the arrows indicate here, here, and here. When a tumor metastasizes, what that means is that the little clusters of tumor cells somehow, due to factors within the tumor, and those cells either invade a lymphatic vessel, which will go to a regional lymph node. That's how tumors may metastasize to a lymph node. Or they can get into vessels such as arteries or veins. And then the natural architecture of the body is going to determine where those cells go next. So for example, a tumor in the gastrointestinal tract might go to the liver, because if it gets into the vasculature, all goes to the liver first. So the liver is a common site of metastasis, and the lungs as well. So typically, when there's ever a malignant tumor case before they decided what to do with that dog ultimately, clinically, they are going to take radiographs of its chest to see if there is evidence of little masses in the lungs. Here you can see what normal lungs looks like under microscope here. Even though it's being invaded by this tumor, we've got this clear space called the alveoli, where oxygen goes into the blood and carbon dioxide comes out. And this is a lymph node metastasized by malignant mammary tumor cells. The arrow indicates the tumor cells. Here we can see the remaining lymph node tissue here. Here's another dog mammary tumor case. 3 masses were submitted to the lab. On cross-section, we can see that the mass over here and the margins were thin, like this here. And microscopically, we observed that the tumor cells were close to the margin, and there were vascular or lymphatic invasion, like here. Other area we can observe inflammatory cells infiltrated at margins, like here. One of the other common things we do with tumor cases is a process called immunohistochemistry, so-called IHC. IHC is we use what we know about certain proteins that are expressed by certain cell types and certain tumor types. That if we are not sure what type of tumor it is, or if we need to subtype the tumor, we can use those cell markers to determine more definitely what type of cells they are, and get a more confident diagnosis or get to a more derived diagnosis than we could get with just a regular HE stain. In addition to detect of tumor cells, IHC has been used to detect pathogens like feline infectious peritonitis or leptospirosis. Okay, there are a few steps in IHC, including phase 1. Start with the sampling the target lesion, followed by tissue fixation, trimming, embedding, and the tissue sectioning, which are the same steps I mentioned earlier in the tissue processing. Phase 2 starts with the deparaffinization of tissue sections and includes all the steps from antigen retrieval and blocking non-specific activities through the binding and detection of primary and secondary antibodies, and ending with counter-staining and cover slipping. Phase 3 includes evaluation of the IHC control, interpretation of results, and the generation of an IHC report. This is an example of normal small intestine. You have multiple layers of muscle on the outer wall, and these beautiful long finger-like villi participate in absorbing all the nutrients in the intestine. In this case, you can see some remaining spaces between some villi, but there are a lot of tiny blue cells instead of normal villi, which is what lymphoma looks like in the intestinal tract. You can see the tumor cells infiltrated in the lamina propria of the mucosa here. And the arrow indicates here that the tumor cells had already invaded into the muscle layers. So we can diagnose lymphoma, but if we want to know if it's from a T cell or a B cell, which end up being important sometimes for prognosis, and how the oncologist might deal with that patient, we can use IHC to determine the origin. In this case, we would use two different cell markers, one that labels the T cells, and one that labels B cells. What we get in this case is that these cells show a positive stamp for B cell marker, like this one, like this picture here. The cell marker is CD20, indicating that all of these cells are B cell origin. Whereas when we do the T cell marker CD3, you can see almost no staining, like this picture. And then, so we combined together to determine it's not just lymphoma, it's a B cell lymphoma. We will do this for all sorts of things. Sometimes when we get sarcomas in the gastrointestinal tract, you can't determine just based on our view of the HE stain what type of sarcoma it is. And sometimes the clinicians will elect to do additional HE stains to determine what the cell of origin is in these sarcomas, because it could make a difference for how they are going to treat the patient. Here's an example of cell markers commonly used in the diagnosis of different round cell tumors. Like this is T cell lymphoma. This includes T cell lymphoma, B cell lymphoma, plasmacytoma, or histiocytic tumor. We can use these cell markers to help us differentiating among them. The tumor grade is based on the analysis of the primary tumor. So for example, one of the tumors that we commonly grade is soft tissue sarcoma. and they are graded as grade 1, 2, or 3. Grade 1 being the best prognosis and grade 3 being the worst prognosis. And we use different features, just like I talked about how we diagnose it based on cellular features and how those cells are arranged in tissue. We will use other factors such as how much mitotic figures there are in the tumor, is there necrosis, how much variability is there in the nuclei, or are there cells with more than one nucleus, which shouldn't happen in most cell types. It's a sign of serious neoplastic change. Here we can see the differentiation score 1. The distinctive rolling pattern closely resembles mature connective tissue surrounding nerves and blood vessels, suggestive of either perivascular or perineural cell phenotype, like this picture here. And the second one is differentiation score 2. Palisading of spindle cells in an Anatomic A pattern are present, suggestive of either perivascular or perineural cell phenotype, but the resemblance to mature perivascular or perineural connective tissue is not as well developed as for the neoplasm of the upper one. And this one is the differentiation score 3. Histological patterns are not evident to indicate a particular phenotype compared with the upper two figures. So we usually do retrospective research to determine the grade, with high grade being worse, low grade being better typically. As you can see in this table, grade 3 soft tissue sarcomas has greatest propensity for metastasis and likely to recur if the margin is close. This is a flow chart of treatment plan for canine soft tissue sarcoma. First of all, after the biopsy specimen is confirmed as soft tissue sarcoma, the surgeon will remove the mass with wide enough surgical margin and send it to the pathology examination. Histopathology can evaluate whether the surgical margin is negative or positive, and whether the tumor invades lymphatic or blood vessels. If the margin is negative according to the histological grade of the tumor, the follow-up plan and the adjuvant chemotherapy can be decided by the clinician and the oncologist. If the margin is positive, the surgeon may consider another operation or adjuvant radiation therapy. Here we talk a little bit about tumor staging. Staging is just looking at where the tumor is already in the body. Is it still just localized to one specific spot where the primary tumor was? Or has it already spread to lymph nodes or potentially to other organs in the body, such as the liver and lungs? Here we can see that T represents the tumor size in diameter, and represent if the lymph node has been involved, and M is metastasis to other organs. Here's the stage grouping. The tumor stage could be determined by the TNN system. So in some tumors, if we say stage 4 or 5, that means it's spread to local lymph nodes and also to distant organs such as the lungs, potentially even the bone marrow. Here I want to talk a little bit about how pathology could help evaluating the prognosis and the survival time of the tumor. Many tumor may have different subtypes and has its own grading system, and based on the microscopic findings, we can make a diagnosis like this: malignant mammary tumor, carcinoma, tubular type, grade 2, without lymphatic or vascular invasion, negative margin. At present, there have been many studies comparing the relationship between different factors and prognosis, like subtype grading or surgical margins mentioned above. Take dog mammary tumor as an example here. The mammary gland tumor could be graded according to this criteria based on the tubular formation, nuclear polymorphism, and the mitotic activity. The degree of tubular formation above 75% get 1 point. Less than 10% get 3 points. If the size of the nucleus are uniform, you get 1 point. But if there's variation in the size and shape of the nuclei with one or more prominent nucleus, you get 3 points. If the mitosis are less than 9, you get 1 point. If the mitosis are greater than 20, you get 3 points. Then add these points to get the total score from 3 to 9. And we can divide the mammary gland tumor into grade 1, 2, and 3. Which is from well differentiated to poorly differentiated mammary gland tumor. Okay, so you can see these curves shows the relationship between different mammary gland tumor subtypes and survival time. The green and the yellow curves represent the anaplastic tumor and the carcinosarcoma, which have shorter survival time than the other subtypes. Following figures are from a 2017 study, which is an observation study about prognostic significance of canine mammary gland tumor. The y-axis is the survival probability, and the x-axis is survival time. Here we can see the blue line, which is grade 1, green line is grade 2, and red line is grade 3. There's shorter survival time of dogs with grade 3 tumors. As we can see in this table, the tumor subtypes versus the median survival time, 1 year and 2 year survival rate. As expected, anaplastic carcinoma and carcinosarcoma have the shortest median survival time, and the survival rate is 0. Dogs with infected invasion had shorter overall survival time compared with dogs without infected invasion, and more frequently developed distant metastasis and local recurrence. Neoplastic infiltration of margins of excision was significant for local recurrence, but did not affect the survival time or distant metastasis. In addition, the tumor diameter was significantly associated with the survival time, local recurrence, and distant metastasis. Okay, thank you. We will take a short break and come back for Q&A section.
The complete Vet Lab's diagnostic test kit of BioGuard is developed to provide accuracy, simplicity, and reliability to your veterinary clinical practice. Canine blood pathogen. The Vet Lab's canine blood pathogen is a lateral flow immunoassay test for rapid and qualitative detection of heartworm, anaplasma, Lyme, Ehrlichia canis in dog's blood, serum, or plasma specimen. Vet Lab's blood pathogen test is an assay that delivers high sensitivity and specificity in just few minutes. The Vet Lab's canine blood pathogen is always ready to use since it can be stored at room temperature between 2 degrees to 30 degrees centigrade. Here's how to run the test. The test can be run in a few simple steps. Step 1. Remove the C-lead pouch, a safe buffer tube, and EDTA blood collection tube from the box. Step 2. Take out the cassette from the foil pouch and place it horizontally on a clean surface. Step 3. Take dog's blood less than 1 milliliter blood into EDTA tube. Step 4. Take sample by disposable dropper from the foil pouch, drip 1 drop about 20 microliter of sample into each well, and immediately drip 3 to 4 drops about 80 microliter of assay buffer into each well. Interpretation. Interpret the result in 5 to 10 minutes. The result after 10 minutes will be invalid. The result is positive when C and T band appear despite T band being vague or not. The result is negative only when C band appears. If C band doesn't appear despite T band appears or not, the result is invalid. The vet lab's canine blood pathogen is your 4-in-1 solution.
Okay, welcome back to our Q&A session. Okay, here are 3 questions here. The first one is, what is the biggest challenge during the pathology diagnosis? Okay, I think the biggest challenge I regularly deal with is just sample quality. Sometimes we get intestinal biopsies, the samples are really small and not full thickness, so not involving nut for that intestine. Those can be challenging. The most challenging things are usually related to small, inadequate sample, or unfortunately a bad sample or something like that. We may have to dewaxing the tissue block, rearrange the tissues, and then cut it into slices to see if there is any lesion in the different section. Or we may recommend the clinician to re-biopsy the lesion. Okay, the second one is, what is the difficulty in interpretation of IHC results? Okay, the first thing is you have to make sure that the tissue is well fixed, because over fixation and under fixation may influence the staining results. And you have to be familiar with the marker you used, where the signal should be located. Is it on the membrane, in the cytoplasm, or both? The other thing is non-specific labeling. This is another problem that may influence the results. At the lowest dilution, all cells and tissues are positive. Epithelial cell, mesenchymal cells, and the extracellular tissues may be colored by the chromogen. With increasing dilution, non-specific background staining disappears from the various tissue components. And at the highest dilutions, there should not be no non-specific background staining. These are the problems that we often see in IHC stains. Okay, the last one is, are there any conditions inconsistent with clinical diagnosis or tentative diagnosis? This situation has happened before, but is not common. This situation is usually seen in the biopsy specimens. For example, if there is a mass about 8 cm in diameter on the patient's back, assuming that the sample taken was not just deep enough and only the area where the capsule of the mass is sampled. So only fibrous connective tissue, fibrocytes, fibroblasts, or even only subcutaneous tissue or muscle tissue can be observed, instead of the real lesion or tumor inside. In this condition, we may not be able to see the real condition of the mass. So then we will discuss with the clinician to see if we can re-biopsy or take large samples for pathology examination by doing another operation. Okay, thank you.